Uh, you see, there is a longitudinal sulcus seen in both vocal cord. স্যার দেখা যাচ্ছে স্যার?
হ্যাঁ,
Hello?
দেখা যাচ্ছে।
There is a longitudinal sulcus involving both vocal cord. Our diagnosis is sulcus vocalis.
Okay, now what is your plan?
Our plans are, I talked with Dr. Santanu Panda sir. He told fat transplantation followed by suturing technique, sir.
ফ্যাট ইমপ্ল্যান্ট করবে, তাই তো?
ফ্যাট ইমপ্ল্যান্ট করে স্যার সুতারিং করে দিবে। ফ্যাটটা সে পিনা থেকে আমরা স্যার ফ্যাটটা কালেক্ট করব।
ওকে
ওকে স্যার, এখন আমাদের পেশেন্ট স্যার আন্ডার হচ্ছে।
হি উইল ডু ইন সিঙ্গেল কর্ড ইউনিল্যাটারাল।
ভয়েস, পেশেন্ট ভয়েস।
2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18
ওকে স্যার।
বাবর তো স্যার
বলো একটু 6 নম্বর সাইজে টিপ দিতে বলো, শুরু থেকে শেষ না 6 বা 7। এখানে কেটে আসে না? হ্যাঁ, আমার এখানে স্পিকারটা নেই, এখানে শোনা যাবে না? ওকে ওকে।
হ্যালো
হ্যালো
হ্যাঁ,
স্যার।
আমি ডাক্তার দিলওয়ার বলছি।
জি স্যার, জি স্যার।
খুব সুন্দর লাগতেছে তোমাদের সবাইকে আর কি।
ও হ্যাঁ স্যার, থ্যাংক ইউ স্যার। পেশেন্টটা স্যার আন্ডার হচ্ছে স্যার, পেশেন্টটা স্যার আর একটু দেরি হবে আর কি।
না না, অসুবিধা নাই, সকালের আভা পড়ছে ইয়ার পর ওটির মধ্যে মনে হচ্ছে।
জি
হ্যাঁ,
স্যার, জি স্যার।
সূর্যের ইয়া পড়ছে মনে হচ্ছে। ভালো
ও
লাগছে।
ওই স্যার লাইটটা রিফ্লেক্টিং হচ্ছে তো।
এই পেশেন্টের কি করা হবে একটু বলো।
স্যার আমরা স্যার এখান থেকে স্যার আমরা এয়ার লেভেল থেকে ফ্যাট নিয়ে ফ্যাটটা ইমপ্ল্যান্ট করা হবে ওখানে করে স্যার। আমরা জাস্ট প্রথমে স্যাকটাকে কেটে দেবো এক্সারসাইজ করে, ওই সালকাসের স্যাকটাকে কেটে ওখানে স্যার আমরা ফ্যাটটা ইমপ্ল্যান্ট করে জাস্ট সুতারিং করে দেওয়া হবে। 50 ভিকে দিয়ে স্যার আমরা সুতারিং করবো স্যার।
এটা কি বাইল্যাটারাল না ইউনিল্যাটারাল?
বাইলেটারাল স্যার, বাইলেটারাল।
দুই দিকেই করতে হবে সেম সিটিং এ?
এখন স্যার সেম সিটিং এ একদিকে বোধহয় করবে স্যার, দেখা যাক স্যার।
হ্যাঁ হ্যাঁ, আচ্ছা ঠিক আছে, ওকে। এটা তো মানে সালকাস ভোকালিস খুব কি কমন নাকি?
সালকাস ভোকালি স্যার মানে অত কমন না স্যার,
হ্যাঁ,
আনকমন।
আনকমন। তা মেইন সমস্যা হয় ভয়েস চেঞ্জ, এটাই তো
স্যার। হ্যাঁ জি স্যার, ভয়েস চেঞ্জ স্যার।
আর ভোকাল ফোল্ডের মধ্যে অ্যাবাউট দ্য ফ্রি মার্জিন থেকে 2-3 মিলিমিটার পরে একটা স্লাইট একটা সালকাস থাকে, এই তো অন এফওএল করলে আমরা দেখতে পারি, তাই তো?
জি স্যার, জি স্যার।
এটার কোনো স্যার জিজ্ঞেস করছে কামরুল স্যার কোনো গ্রেড টেড আছে কিনা, এটার গ্রেড 1 গ্রেড 2 3 4 এরকম বলতে পারবা?
এটা গেটিংটা স্যার আমি
আচ্ছা,
বলতে পারবো না স্যার।
ঠিক আছে, ওকে, না নো প্রবলেম। ঠিক আছে, হ্যাঁ।
সবসময় ট্রমার হিস্ট্রি থাকে না কনজেনিটাল হইতে পারে?
না স্যার, ট্রমার হিস্ট্রি থাকে না স্যার, এই কেসে তো ট্রমার হিস্ট্রি নাই।
না এটা কি মানে মানে যে জায়গাটা, এটা তো মাসেলের মধ্যে একটা
মাস্টার স্যার, হ্যাঁ
ডিজেনারেশন চেঞ্জ হয়, যে কারণে ওই জায়গা সালকাস হয়ে যায়, তাই তো নাকি?
রাইট রাইট স্যার।
তাহলে তোমার মিকোসাটা ওই স্যাক যেটা ভিতরে ঢুকে গেছে ওটা কেটে ফেলে ওর মধ্যে
ওইটা কেটে
ফ্যাট দিয়ে
ফেলে
স্টিচ করবা।
রাইট স্যার, ওইটা হ্যাঁ
ওইটাই, ওকে,
ওইটাই করা।
ওকে
স্যার।
হ্যালো ডক্টর
জি ম্যাডাম, জি ম্যাডাম, জি ম্যাডাম।
এই সালকাস ভোকালিজের অপারেশনটা যিনি করবেন, যে সার্জন করবেন, উনি যদি একটু ফ্রি থাকে তাহলে
জি
বলো
ম্যাডাম।
স্যার একটু সালকাস ভোকালিজের উপর একটু একটা
ওকে
বলেন,
এক্ষুনি
মানে অডিয়েন্স শুনতে চাচ্ছে। কনজেনিটাল অ্যাকোয়ার্ড কিরকম পাওয়া যায়, কত পার্সেন্টের হয়, দুই ইয়েতে করে কিনা, হ্যাঁ এগুলো আমরা জানতে চাচ্ছি।
ক্যামেরা দাও, ক্যামেরা দাও, ক্যামেরা দাও। হ্যাঁ স্যার ক্যামেরা দাও, হ্যাঁ লেজার লেজার। এই স্যারকে ক্যামেরা দাও, 1 মিনিট। ম্যাডাম একটু ম্যাডাম স্যারকে ক্যামেরা দেওয়া হচ্ছে এখানে ওই, বুঝছেন? একটু ডেমনস্ট্রেট করবেন সার্কাস ভোকালিস্ট নিয়ে একটু ডেমনস্ট্রেট করতে হবে অডিয়েন্স শুনতেছে এটা কি প্ল্যান করবে
নাকি একবারে ওটি যখন চলবে তখন করবো নাকি এখন?
একটু ডিপ দেন স্যার কারণ ওই
ঠিক আছে। Let me know when I'm on.
ফিজিক্যাল ল্যাব পেপার আমার তো হ্যান্ডেল তো নাই আর হচ্ছে পিয়ার্স নাই তো না পিয়ার্স আছে আমাদের লম্বা পিয়ার্স তো নাই একদম তাহলে তুমি ইয়ে নাও এই যে এমিলের যে সেট আছে না যে হ্যালো
হ্যালো
হ্যালো ম্যাডাম শোনা যাচ্ছে কথা হ্যাঁ স্যার কথা বলেন স্যার শোনা যাচ্ছে
Hello.
হ্যাঁ
Hello, good morning, sir. We want to know about the sulcus vocalis in short.
Yeah, can you hear me now?
Yes, sir.
Yes, yes. Very good morning, everyone. We had a wonderful evening last night. I think everyone is back to action today. So we have this case, a 19-year-old female who has a history of hoarseness of voice since childhood. There is no history of trauma or surgery to the neck and no respiratory distress as such. So it's a raspy voice that the girl has. So when fiber optic laryngoscopy was done, we saw that there is sulcus vocalis on both the vocal cords. As you know, it's a very unusual anomaly of the vocal cords, and the incidence is extremely variable. So you find it from about 0.4% to 48% cases. That there's a huge variability of cases that is found, and many a times retrospectively in pathological specimens also it has been found that there is existence of sulcus. So it's largely underdiagnosed in many situations.
And I think
Yeah.
I think we get during FOL minor sulcus in many cases, asymptomatic
Yes,
sulcus.
yes, yes, exactly, exactly. So it's like what we actually treat is just the tip of the iceberg. As you know, that vocal cord is a layered structure. There are several layers, and it has to be supple and pliable to produce a good quality voice. So there is a lot of variability in the presence of sulcus. So broadly, it has been classified into two groups. So there is a physiological sulcus and there is a pathological sulcus. Physiological sulcus you find in several patients, which is the type 1. Most of the times, you know, if you like give voice therapy or speech therapy, that is the basic minimum which is done, and usually they don't do that bad. There are other two types which are the pathological ones. One is sulcus vergature. The case that we have is classically that. It's a type 2. You will see that the sulcus is there along almost along the whole length. So the major part of the cord is involved with the sulcus. And the third is like it's like a pouch kind of a thing. And there the lamina propria, it is almost it infiltrates the lamina propria and goes up to the vocal ligaments. So we have this kind of variability. This case is a bilateral sulcus. Treatment of sulcus, we all know it's a little frustrating because you know, mostly in all kind of modalities has been tried. The findings are best appreciated in a stroboscopy in early sulcus as Dr. Babar was telling that many a times we miss. So in stroboscopy, you find that absence of mucosal wave in a particular area, and that can give you an idea that probably there is some kind of sulcus in that area. So treatment wise, I think a lot has been tried as far as sulcus is considered. Different type of injections, etc., has been carried out. But they are all temporary measures. Most of the times they get absorbed. What we had experienced with the Radis gel, which is basically calcium hydroxyapatite, we used to see that they used to stay for quite some time. But I don't know whether it is readily available these days. So we will surgically demonstrate, and we will try to, I'll take you through what we would try to do. Right now, our wonderful anesthesia colleagues, they have intubated, and you see, we had a communication regarding the tube. We would obviously required a microlaryngoscopic tube, which would be of the smallest size for us. That is to our advantage. But then our friends, they also have to maintain the airway. So somewhere we have to strike the balance. So I think they have put a 5.5 mlt, if I'm not wrong. Yes, fantastic. So 5.5 microlaryngoscopic tube has been put, because here you see.
Expected time of surgery.
Mhm.
In terms of expected time of surgery.
Expected time.
আধা ঘন্টা।
1 hour.
1 ঘন্টা, 1 ঘন্টা। You both sides. Okay, so I think the patient is induced now, so we will go ahead with the here, and when we start again, I'll come back to you after creating the exposure for this patient. Okay.
Basically, this is the disease of the mucosa or muscle layer. Basically.
Yes. Actually, it doesn't penetrate the muscle per se. It is actually the lamina propria layers.
Yeah.
See, there is a superficial layer, there is a deep layer, and the intermediate deep layer, they constitute the vocalis ligament. So it goes up to the vocalis ligament in most of the parts. It's something very interesting. There's an interesting observation. It is said that many of the sulcus, they are actually ruptured epidermal cysts, congenital epidermal cysts which have ruptured. And interestingly, in Indian subcontinent, especially in India, Bangladesh, all these areas, there is a very high incidence, and it is like attributed to this ruptured epidermal inclusion cyst. So probably that is the reason why we also get to see a lot. And there are some studies which said that many a times it can be familial also. I mean, it can be in the family. I have a interesting story. One of our neurosurgery colleagues, when he joined our hospital, everyone noticed that he had a raspy kind of a hoarse voice. Okay, so many of our friends and colleagues recommended him that why aren't you going to the ENT department? They will cure your problem if you are having a hoarse voice. Okay, but he was taken aback and furious. This is my family legacy. My father had this kind of voice. My grandfather had this kind of voice. So even I also have. So I want to maintain this. Well, fair enough. But now, on the hindsight, I realize probably he might be having a sulcus vocalis, which is familial, and it has been carried in the family for generations.
Yes, Panja.
So,
One of our colleagues have pneumonia, a senior professor of this university. I told him the treatment of pneumonia is very easy. You can come and
yes.
we try. He said, no, I don't want to change my voice now.
Yeah, that becomes more embarrassing when you reach a certain
He
age.
loves his voice, puberphonia voice.
Okay, okay. That's great. So I think let's get the tray ready. I'll scrub up. And then we will take you through after we create the exposure.
Okay,
Sir, আসেন।
অহেদ অহেদ তো নাই ডক্টর অহেদ
স্যার, শোনা যাচ্ছে স্যার?
হ্যাঁ হ্যাঁ আমি বলছি
স্যার।
তোমরা কি এই কেসে কি লেজার ইউজ করবা কোনো
না না স্যার, এখানে স্যার ওই যে কোল্ড
হোল ইনস্ট্রুমেন্ট দিয়ে করতে হবে না
রাইট স্যার, জি স্যার।
আচ্ছা আচ্ছা ওকে
এখানে সিকেল নাইফ ইউজ করা হবে। সিকেল নাইফ বলছেন আমাদের স্যার, ফ্রিয়ার্স তো নাই, ফ্রিয়ার্স তো চেয়েছিলেন স্যার। সিকেল নাইফ দিয়ে স্যার ইয়ে করা হবে আর কি।
আমাদের ওটিতে হ্যাবিট আছে ভেতরে।
ভাই আসিফ, আমাদের না ইয়ে ছিল, ফ্রিয়ার্স ছিল, ফ্রিয়ার্স ছিল না, ফ্রিয়ার্স ফ্রিয়ার্স ফ্রিয়ার্স
তাহলে রিজিড ল্যারিঙ্গোস্কোপ দিয়ে কি মাইক্রোস্কোপ দিয়ে করবে না এ দিয়ে করবা
মাইক্রোস্কোপ দিয়ে স্যার, মাইক্রোস্কোপ দিয়ে অবশ্যই।
এন্ডোস্কোপ দিয়েও তো করা যায় এন্ডোস্কোপ দিয়ে করা যায় না
এন্ডোস্কোপ দিয়ে করা যায়। এন্ডোস্কোপে স্যার ডিফিকাল্ট স্যার, একজন ধরে রাখতে হয়, ঝামেলা আছে। আমাদের এন্ডোস্কোপ হোল্ডার তো নাই স্যার, এই জন্য স্যার।
হ্যাঁ হোল্ডার থাকলে ভালো হতো এন্ডোস্কোপ দিয়ে দিলে ইজি হয় আর কি
Seven and a half.
আমাদের ওই ইনস্ট্রুমেন্ট গুলো এখন আসলে ভালো হতো, যেগুলো আমি লিখে দিচ্ছিলাম।
আচ্ছা, একটু স্যালাইন এপিনেফ্রিন নেবে যেটা ইনজেক্ট করবো, ঠিক আছে?
একটু নরমাল স্যালাইন দিয়ে।
What is the composition of that? 2% xylocaine adrenaline আছে? 2% xylocaine এরিয়া থাকলে হবে, অথবা জাস্ট ইয়ে করো 5 ml স্যালাইনে দুটো এপিনেফ্রিন দিয়ে দাও, দিয়ে ওটা থেকে টেনে নাও ফুল মাঝে, ঠিক আছে? যেটা ইনজেক্ট করবো না পডে।
ওকে পাঞ্জা
We have to do we have to use a rigid because we need a static field, probably now these days there are laryngoscopes through which you can also pass an endoscope. If
Yeah.
that is the tool which is available, that would be great.
Okay.
But here probably we'll have to do things under magnification. So is a better tool.
You will infiltrate the vocal cord.
So let me create the exposure and then I'll tell you. Okay, এটা কি
Okay.
করাতে হবে first time.
স্যার 5 ml নরমাল স্যালাইনের মধ্যে দুটো অ্যাড্রিন নেওয়া হবে না, ওটা দিয়ে স্যার ভোকাল কর্ড ইনফিল্ট্রেট করা হবে।
5 ml
নরমাল স্যালাইন স্যার,
দেখি গজ পিস
5 ml নরমাল স্যালাইনের মধ্যে দুটো অ্যাড্রিন দাও। হ্যাঁ
বাবা এত কনসেন্ট্রেশন
জি স্যার।
About that infiltration, you see, vocal cord is a structure where there is very less vascularity.
Yeah.
So even if you use that concentration, it's not going to create any problem. So
Yeah.
our entire idea is that we are not going to use a laser over here because we don't have a CO2 laser. With diode, it won't work in this case. And moreover, diode can cause a lot of fibrosis later on. So ideal would have been a CO2 laser because the collateral tissue damage is very less. The cut is very precise. But since we don't have a CO2 laser, I usually always use a CO2 laser. We'll be using cold knife. So we would want as much hemostasis as possible while we are operating. So what we are going to do is that we are going to infiltrate the cord with that solution, a bit of that solution, so that we get a good feel. And first, let us expose the cords, and then we can take forward the discussion.
Okay, okay.
Okay. Thanks. Okay, so we have a fantastic exposure, and I'll show you. This is very important for the residents to learn how to create an exposure. Yesterday, I was telling about exposure in my lecture. Okay, so can you see?
By microscope
Yeah, you can see the microscope view.
Okay, so we have the entire thing which is exposed nicely. So
Before that, please white balance the field. এটা গজ দিয়ে দাও, গজ দিয়ে হোয়াইটটা ব্যালেন্স করে নাও, তাহলে আরো ভালো দেখা যাবে।
হোয়াইট গজ দাও এটা।
হোয়াইট দিয়ে, হ্যাঁ, হোয়াইট ব্যালেন্স করেন।
আরো দূরে ধরে। ওকে না,
ওকে ওকে ওকে
এটা খুলে দাও।
ক্যারেক্টার রিমুভ করো।
এটা না করলে ভালো হতো।
Light maximum. Where is the light?
লাইটটা কমাও একটু।
Maximum for. Yes. Okay. Do you have a good view now?
The view is okay, but the glare is more here. Reflection of the light here.
That is because of the. No.
এই লাইট দিলে ওই লাইটটা বন্ধ রাখলে মনে সুন্দর আসবে আপনার দেখতে
না, সেভাবে বললে হবে না। It is because it's peripherally getting reflected from the metallic DL scope, I guess.
ঠিক আছে স্যার ঠিক আছে
Okay, okay, okay.
এখন তো দেখা যাচ্ছে।
হ্যাঁ হ্যাঁ, এখন চলবে,
চলবে। ওকে,
কিন্তু মুভমেন্ট বেশি হচ্ছে, মুভমেন্টটা ফিক্স করে দেন একটু।
এখন স্যার ঠিক হয়ে যাবে স্যার।
অ্যাঙ্গেল রাখলে রিফ্লেকশন হবে না স্যার।
হ্যাঁ,
Okay.
Okay.
এই বাটারফ্লাই নিডল তো
So you see,
বাটারফ্লাই নিডল
give me some blunt probe or something.
বাটারফ্লাই
Yes.
নিডল দেন আরে
ওয়াহেদ তোমার
স্যার
তোমার হেডফোনটা বন্ধ রাখো, নাহলে সব দিক থেকে নয়েজ আসতেছে। শুধু
Okay.
একজন সার্জনের হেডফোনটা অন করে রাখো।
Give me a fine straight forceps then. So there are some instruments which are required here. That is, one is the blunt dissector.
Yeah.
So here you can see this is the sulcus area. Okay,
Yeah.
it's bilaterally present the entire length. You can see how that area looks thinned out.
Yeah.
Ah,
And this is
compared-
very long sulcus.
Very long sulcus. This is
Yeah,
what I
yeah.
was exactly telling. It is a type 2, it is sulcus vergature, which runs across the entire length. The type 3, it's more like a pouch kind.
Oh, yeah.
This is a long sulcus. And let's see what best we can do with the instrumentation that we have. So what we will try to do is that we'll give an incision in the superior lip of the sulcus, and we will try to dissect out the sac and lift it up from the underlying tissue. Sometimes that area is so thin and adhered that it might tear as well, that sac fundus. Okay. So
Okay. Please centralize the picture. There is a one-sided, both vocal tight in the mid position. Yes, that's okay. Oh, no.
one second, I'll do it. Wait.
Oh, okay.
Okay.
Yeah.
So that is definitely a possibility. But if we are able to lift up the sac and
Hmm.
dissect it out, what we will try to do is a fat implant in that space.
Mhm.
Okay. So I usually take the fat from the ear lobule because it is close to my area field of surgery that I am doing.
Yeah.
I can also take from the abdomen, which is routinely, fat is harvested from the abdomen for injection purposes. And but then again, you have to, have another area of operative field which you have to prepare and do. But this is in my close proximity. I can just take a fat, and there is not much fat required. So that is easily can be harvested from the ear lobule on either side. And we will try to put it. And if possible, we will try to put a suture to close the lips. What in my center, what I use the fibrin glue.
Yeah.
So to close the margin. So these are the tools which are required to do it. But let's see what best we can do here. I would like to have a patty to keep in the subglottis.
Panja,
Yes,
hello.
tell me.
If this we saw the sac in a deep depression, if
Mhm.
we push the fat in below the sac and without excision of the sac, it will fulfill the purpose of the vocal cord.
Look, the point is that for sulcus, a lot of things has been tried,
Yeah.
There are a lot of injections has been tried, but the basic problem is with the, the developmental architecture of the cord itself. Okay.
Yeah. Mhm.
So whatever it is, at least if the sac is lifted and if there is fat doesn't stay lifelong, but that space is created, and it has been found that they give good results. And sometimes a supplementary injection might be required. So there is one paper where they have done a fat grafting with selective supplementary injection, and the results were pretty good. It was a case of 33 case series.
Okay.
So that is one of the techniques. Now there are variety of techniques which has been followed and done. Like people have put cartilage, people have put different other type of biomaterials. I have used the Redis, which is calcium hydroxyapatite
Yeah.
material, I found it worked well, and it stayed for about 6 months without any problem, and even in the later stage also patient did well. But that is not readily available these days. So it's difficult to get. But then again, whatever biomaterial you put, they are not, they will not stay for too long. So let's see. You have got the injection ready. You can take the solution in a 2 ml actually.
But in literature, it is shown that there is a carbon dioxide appetite, calcium Kaha, which is a very long duration of stability.
Yes,
more than
that is
1 or
what
2
I'm.
years.
That is what I'm telling, because I have personal experience in using that material.
Yeah.
So Reddy's has that calcium hydroxyapatite, and it really stayed for a very long. In fact, it can stay up to 2 years.
Yeah.
Minimum of 6 and maximum of 2. Okay, let's see. Right.
So now you're infiltrating local.
Filtrate. Inject. Yes, that's it. Okay. Give me a patty.
Normal. Huh?
So you have to be very careful that you don't infiltrate it too much inside. थोड़ा ज़्यादा हो गया infiltration. But
you are infiltrating normal saline or lignocaine?
Normal saline with epinephrine.
Okay.
With
Or
ADI.
hydrodissection.
Yes. It will make my life a bit easier, I guess. Plus, it will cause, I'll get some hemostasis. Plus, the sac will get lifted because it is so thin. Sometimes, if you try to do a dry dissection, it might give me a suction. It might tear. So you can give a little less water maybe, but fine, it's okay. The trick is that it has to be sub mucosal. I mean, you should not put your needle too deep to guide my. Okay. 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 We usually wait for some time and give me a sickle knife. No, we have a sickle knife holder. Wait, let me see if we can do it like. So give me a bigger artery. The problem with this sickle knife is that it is not having the handle. So I'm finding it a bit difficult to bridge the length. Sickle knife handle is very important, because otherwise, if you hold a sickle knife, it doesn't go the entire length.
Panja, Dr.
Yes,
Panja,
yes.
the
Yeah.
not clear. There is a whitish.
I know. The reason is, I think probably my gloves is in between. The
Yeah.
reason being that there's no sickle knife handle. So I have to,
Oh,
hold the sickle
close.
knife in my hand, and my hand is very close to the aperture of the DL scope. So it is, you're finding it a bit obstructed. But anyways, I'll show you. Let me complete the incision.
Okay, okay.
Okay. Give me a micro Caesar.
You give the incision in the whole length of the sulcus?
As long as the sulcus is there, we will. Okay, give me a patty. Okay, so I think you can see the incision. Now, one thing you must have noticed
Yeah.
that I started the incision from the point where I gave the injection.
Yeah.
So there is no extra traumatic point which is there. So
Okay.
the technique is that we try to be as atraumatic as possible. So we don't. So when we are giving the infiltration, we are already creating a hole, and we already have created a guide for entering our sickle knife.
Okay.
So, okay, so I'm not putting it in, I'm just continuing with that. Entered through that hole, I've entered the tip of my sickle knife, and I've
Yeah.
given incision up and down, and it very easily opened up. So we will try to dissect now. Let me see which instrument I get to dissect. Here you need a dissector ideally. And sometimes, something like in our ear cases, we use a Bills or a microperiostome elevator.
Yeah, yeah,
That type of instrument helps a lot.
yeah, yeah.
If it is not available, sometimes it's a good idea to talk to your vendor and make one instrument like that. Or the sickle knife can be used, and it gives a sharp dissection, and it helps. The sickle knife helps because, but for that, it's important to have the handle. So let's see. No, you give me a finer forceps, a grasping the angled with the eye, যেটা আছে না MLS এ যেটা ফাইন আমরা ইউজ করি এটা দেখি one second. These are scissors. আমি কালকে একটা দেখছিলাম ফরসেপস এ আই থাকে একটা যেটা these are cup forceps. I'm asking for a grasping forceps. There is a grasping forceps. I had seen it earlier. See. Okay, till then give me the scissors. No, there is a grasping forceps. You go and find out. The grass, yeah.
Now you're trying to free the vocal cord from the vocal fold. That is
Yeah.
your.
No. Give me the scissor. Yeah, I'm trying to free that mucosa. Guide my hand from time to time. Okay. I wish I had a dissector here because it really helps. But I'm trying it with the tip of my scissors. Okay, so you can see the space now. You can see the space.
Yeah.
Okay.
Yeah.
So we have lifted the sac. You can the entire idea is to, maybe sometimes a bit of puff of tissue also we can keep with the sac. And the entire idea is to medialize the sac to some extent. Because if it is too thin, okay, so we have created the space
In between.
in between the sac.
Yeah.
I've gone a little, I've kept a cuff of subepithelial tissue. And lifted up the sac from the underlying area. So, okay, I need a wall. Give me a ADR plate. Okay, give me a wait. You have the sickle. Let me hold the sickle. So without a dissector, it is very tricky to dissect it because it needs a, sorry, put it in the ear. It needs a very gentle dissection because the layers are very thin. So if it is too thin and when it is absolutely adhered, because when it is stuck or like it is sticking on the thing and while creating flap, obviously that stuck tissue, it is so thin that you won't be able to completely lift it and it is going to stay with the underlying tissue. So in those type of cases, I leave a small cuff of tissue on that deep part of the sac and create a space in that area. Okay, so they are preparing the sickle so that I can show you that space. Okay, let me see with this if I can show you. You can now appreciate, you can see that the sulcus is getting lifted with the pressure of my.
Your hand is blocking this area.
Wait, let me, that's why. Okay, they have prepared the sickle somehow. Let's see if it works. यार ये काम नहीं करेगा.
You are doing just elevate the sac. And
Yes, yes, yes.
create
And
a
this is the
space.
most trickiest part of the, one of the trickiest part of the procedure is this step.
Yeah.
Hmm.
Very thin area, no doubt. Just create a space and you will filtrate fat in space. That is your
We will,
idea.
yes. We will put a fat graft in that area. Let me just show you what I want. Acha. No, you leave it. इससे नहीं होगा. You give me a. ठीक है, that Caesar only you give me. Let me show you. So you need to have the right kind of instruments actually. You prepare the instrument set when you do this. So can you see? Okay. So here, yeah. Now can you appreciate that the sac is lifted because I'm putting my. Okay.
Okay.
So the thing is that the fundus of the sac, the lowest fundus of the sac,
Yes.
that area is absolutely adhered. It is like plastered. Okay.
Yes.
So if you go too close to that, definitely that plastered area you cannot lift because there is no, you cannot create a plane in that particular area.
Okay.
So what I do, I leave a small cuff of tissue on that plastered area. Okay, while I'm dissecting. So here you see this here. Okay.
Yes.
So here we have the space, right? So what we are trying to do is we will take some fat and we will put in this space. Now, similarly, on the other side, the sulcus looks even deeper compared to the right.
Yeah.
So it is really a very deep, almost, although it is across the whole length, but in some areas, it is like the type 3, which is completely plastered. It's going up to the almost up to the vocal ligament. Give me a straight plain forceps, cup forceps, straight small one. So okay, here you see the entire length. Okay, that area is absolutely thinned out. Okay, the left side.
Yeah.
So let us try to inject that area. Give me the injection. That infiltration. Okay. Fine. Good. Give. যখন বলবো তখন করবে। Okay, push. Yeah, that's it. Okay. So I think you can see that the sulcus, that mucus, it has got completely lifted.
Yeah.
Yes.
Okay. So it's very important where your plane of injection is. If you are in the too much of a deep plane, you won't see this kind of lifting of the entire sulcus. Okay, so you have to be in the right plane. So that is something, you know, I say it comes here. You have to develop your experience and maybe keep practicing. this thing and you know exactly how to do it. Give me a suction.
কাকিমাটা এনে পছন্দ করে রেখে দাও।
Okay. Now give me the sickle. Emni sickle now. না না এটাতে খুলে দাও দরকার নেই। Give me a patty till then. Straight ইয়েতে দাও। Straight foster. ADR আছে? Okay. So here again you can see the small hole which got created because of the injection.
Yeah.
Okay. So what I do, I always start my incision from there. You will find it difficult to see, I guess, because of the hand now, because I don't have a handle of the sickle. My hand is probably blocking the our white is looking so red in the I think what you can see over there is probably very red.
White balance করো।
Probably a very red field. It
পাঞ্জাব,
is not so.
white
Yeah.
white balance করতে বলো, white balance।
Okay, I think please do it because I think we are scaring people.
Okay.
হোয়াইট ইয়ে হয়ে গেল কেন?
হয়েছে white balance হয়েছে? Okay.
না হোয়াইট কেমন হলো?
না আবার করো তাহলে। আরেকবার করো।
হোয়াইট প্লাস একবার করলেই তো হয়, বারবার
লেন্সের সামনে এসো, মাইক্রোস্কোপ লেন্সের সামনে এসো।
তো মাইক্রোস্কোপ তো অফ করে নেই।
সরি লাইটটা জিরো বানাই দাও।
আচ্ছা, জিরো কর।
জিরো হ্যাঁ। কোন হবে? এবার হোয়াইট কিছু দেন। না ওই যে ইয়ার মুখে রাখেন। হ্যাঁ জুম বেশি স্যার, জুমের জন্য এটা স্যার।
ঠিক আছে, ছাড়ো।
জুম বেশি তো এই জন্য।
Anyways, ঠিক আছে, doesn't matter. চলো, let us go ahead.
ঝাপসা হয়ে গেছে।
হাতের ইয়ে পড়তেছে।
Don't move it. Don't move the position. No?
ম্যাডাম একটু এই হাত হাত দিয়ে নড়ে এটা এই যে আবার নড়বে ছেড়ে দিলে
Ma'am,
নড়বে
please don't touch the bed. Position is same. Give me a patty.
এই রোগীর বেডের সাথে কেউ হেলান দিও না, আর মাইক্রোস্কোপের সাথে কেউ টাচ করো না।
You see, right, left side is oozing a bit compared to the right side. You know why it is so? Because right side we waited for some time for the epinephrine to act, and here we have started the surgery early. So again, another learning: when you infiltrate, you wait for 2 minutes so that the epinephrine take action. Your field will be much better. Okay. এটা তো বার করো, right? Take this out. Okay. Now, give me the grasping posture. Hmm. Slipping bit. Give me the scissor. You don't have a dissector. I'm using the scissor to dissect. So you can see I've gone to the lower end of the flap. Okay, there will be some oozing because we have again left a small cup of tissue in the ideally we should have a very fine grasping forceps and a dissector. These are the two instruments which are very important when we are doing this type of fine microlaryngeal procedure. So that helps to dissect in the plane with much ease. So the idea is to go up to the lower end of the sac and lift it up so that there is a space. Need to remove it. At a straight force, we can have this option. Okay, give me the patty 1 second.
ছবি একটু সাদা আসতেছে, বোঝা যায় না। ওয়াহিদ, আর একটু ক্লিয়ার করা যায় নাকি? একদম সাদা, কিছুই বোঝা যাচ্ছে
না। ক্লিয়ার করার চেষ্টা হচ্ছে।
ক্যামেরা এটা কেন এরকম হচ্ছে? এটা তো পুরো হোয়াইট আসছে। Even I am also finding problem in wait.
এন্ডোস্কোপ দিলে আবার ইয়ে হবে, এটা
দাঁড়াও
কাজ করে
দাঁড়াও,
দেবে।
let me it first
তুমি
for my
টেলিভিশন কাজ
focus.
করতে পারবে না।
Okay. এটা না, I think the color filter is not right.
মাইক্রোস্কোপ এমন ছিল না, দেখো তো কোনো জায়গায় কোনো সমস্যা হয়েছে?
There is, I think the filter is আমি এখানে দেখতে পাচ্ছি, but transmission is not.
গতকালকে এটা কথা বলছি না, গতকালকে হ্যাঁ তাহলে
পুরো ব্লু হয়ে গেছে ওখানে।
একটু আবার লাইটটা জিরো বানান।
ট্রান্সমিশন দেখেন তো কোথায় প্রবলেম হচ্ছে।
Light is off now. Okay, meanwhile, let us take the fat.
লাইট দেন স্যার, এন্ডোস্কোপ দেবো স্যার?
না, endoscope
কাজ
দিয়ে
করে
তো
দেবে
ইয়ে
না,
করা যাবে।
ডিসপ্লে কাজ করে দেবে না।
আমরা এটাকে ফ্যাটটা নিয়ে নিই, ওরা ঠিক করে দেবো। আপনারা ঠিক করে
ঠিক আছে, let it be. এটাকে
পাশেরটা তো যদি
বলবো।
এটা দেখান ওয়াহিদ, তোমাদের ওখানে দেখো এই ক্যামেরার লোক আছে, হ্যাঁ?
হ্যাঁ।
মাইক্রোস্কোপে যে কালার, সে কালারটা আমরা পাচ্ছি না। ওদেরকে
স্যার এখন
টপ লাইট
ফ্যাট হারভেস্ট করা হবে স্যার,
Top
ফ্যাট
light.
অ্যালোভেল থেকে তো ফ্যাট নেওয়া হবে।
লোবুলার ফ্যাট বাদ দাও, তুমি মাইক্রোস্কোপ ঠিক করো।
স্যার
মাইক্রোস্কোপ কালো হয়ে গেল কেন?
না, এখন
না,
তোমরা
না,
মাইক্রোস্কোপ সেপারেটলি ওখানে চেক করে দেখো, ঠিক
হ্যাঁ।
আছে? আমরা পরে আবার যখন
হ্যাঁ,
নেব তখন it should be off.
গতকাল এডিটে করা হয়েছে না, গতকালকে
মাইক্রোস্কোপ অফ করে অন করো আবার নতুন করে।
Okay, give me injection 2% xylocaine with ADR.
ফ্যাট নিয়ে আমরা এডিটে করি।
2% xylocaine with adrenaline. আচ্ছা।
দেওটা জ্বালা
এডিটে দেখুন।
আচ্ছা, এই অ্যারেঞ্জমেন্টটাকে ডিস্টার্ব না করে আমরা কাজ করবো, ঠিক আছে?
সো উই নিড
এটার উপর রেখো না, এখানে রাখো। Don't keep it on the tray, keep it here.
ইলেকশন করতে আছে
কিছু লাগবে না, I just need a first infiltration, then I'll use the scissor, then আমার একটা ছোট ওই sharp knife. হ্যাঁ, hold it first. Wait for some time. Fine scissor, possibly.
ফাইন।
Can you use one? Yes, yes. Can you give ছোট সিজার আছে?
আপনি ওটা দেন এই পাশেরটা
ঠিক আছে, একটা সাকশন হাতে মাইক্রো ইনস্ট্রুমেন্ট যেগুলো হয় না, ফাইন সিজার যেগুলো আইরিস সিজার হয়,
এখানে সমস্যা নাই হয়তো ওদের কেবলে নাহলে কোনো ইয়ে সমস্যা মাইক্রোস্কোপি
দুদিকে দুজনে করে রাখো, একই লেভেলে রাখো, এরকম ভাবে না, ছেড়ে দাও। এগুলো করে একদম। ঠিক আছে, সাক্ষী দেবে।
টাকাটা লাগায় রাখেন গালিপট
Responsibility.
ফাইনাল আপনারা দিল্লি
বাটন হোলিং হয়ে যাবে, লেফট উপর দিকে লিফট করতে হবে, লিফট লাগবে। Hmm?
ফরক্লোজার
50 এটাকে তোমরা এখানে কিছু এনিথিং ছেড়ে দাও। ইনফ্যাক্ট আই হ্যাভ টেকেন আ বিট বিগার ইনসিশন, otherwise we give very small incision and we don't even give a suture, we just close it with a steady strip, that's all.
Yes, sir.
And it automatically heals. Here if you want you can actually lobule is very vascular, so it heals very well. You can actually press it for some time, the hemostasis will happen, and if you put a steady strip also, then also you will find that it has healed.
Yes, sir.
Okay. But you can give 1 or 2 sutures over here. You see the bleeding has totally stopped here. So the advantage of taking the lobule fat is that I'm not having to open another area of harvest. Okay, it is, you can, the same principle goes why we take a temporalis fascia. We don't take a fascia lata for doing a tympanoplasty.
Yes.
Okay, it is in proximity of our operative field. So and you don't need too much fat. If you are doing an injection, then your fat harvest should be more. But when you are doing a fat implant over there, you need this much fat would be enough. And one lobule you have harvested this. If you require some more, the other lobule is also there. You can harvest from there. So we find this technique very simple and effective. And without causing any other donor site morbidity, right? So, wait, this is what?
Hello, Dr. Panja.
Yeah, please tell me.
Very good morning to you. Dr. Bollav is here. Which one is,
Yes, sir.
you think, best, fat injection or fat transplant?
Both doesn't stay lifelong. So let us be honest with ourselves. Okay, the problem, but I think the implanted fat, one advantage is that while we are doing the fat implant, we are actually lifting up the sac from the underlying thing. So that helps. Sometimes sac excision can also be done.
Yes.
And we put a fibrin glue. Fibrin glue, the advantage of fibrin glue is that we prefer using it when we are excising the sac actually, because many a times it happens. You see, it is so thin. If you are going exactly, you are hugging the plane between the mucosal layer and this thing, the underlying tissue. Very high chance in cases of deep sulcuses, no, very high chance that it will tear and you will have to excise the entire sac. So you are left with two free margins. So for apposition of the free margins, fibrin glue is very appropriate. Okay, because it sticks them. Second thing is that it also helps in healing. You know, it has got some amount of regenerative property. That is why in post-operative beds, fibrin glue is given. So we have seen that it works well. Problem with fibrin glue is that it has to be prepared. So you need a kind of device and set for which it is, which can help it to prepare. And number two, it is costly. Okay, so the cost is another constraint in most of the patients, and it's a one-time use. It's not like Botox, like you use in some patients and then you can keep it and again it can be used.
In Dhaka, it costs about 20,000 taka.
Yeah, yeah.
Fibrin glue.
So it is expensive.
Uh,
But
we used in some cases of CSF rhinorrhea experimentally, but we found no benefit of using fibrin glue in CSF rhinorrhea.
CSF rhinorrhea,
We found the
yes.
result same, but extra disadvantage is to keep the pack for 7 days without fibrin glue.
Actually, in CSF rhinorrhea, there are different schools of thought. In like, I have operated quite a few big defects endoscopically, and I have always used a cartilage to cover those defects endoscopic. So when I'm operating, I sometimes harvest the nasal cartilage and I use it. So if you can tug it and, you know, if you do a scoring of the cartilage and put it inside and it snugly fits, it's a fantastic blockage for CSF rhinorrhea. On top of that, if you give a Haddad flap, I'm going into rhinology a bit because that is also one of my.
But other flap and cartilages are needed in exceptional cases, I think, not in all cases.
Yes, yes. In those defects which are more than say around 4 centimeter.
Yeah.
Those type of big defects. So I have quite a few because I have had cases where there was brain fungus and, you know, meningoencephaloceles, which I had to operate. There I always use a cartilage. Otherwise, if you put a fat and if you put a fibrin glue is in isolation, it never helps.
Yes.
But it always has to be used along with other layers. So suppose if you put a flap and if you put a Haddad flap, okay, you know, around it you can put a fibrin glue maybe. But if you don't have, then you have to rely on your proper accurate layering and closure. That is very important. And you have to, yes, keep for some more time the pack, but it works.
No doubt, fibrin glue is the best, no doubt.
Not best. It works, not best.
No, no, no. What is the function of the fibrin glue?
Fibrin glue is
It is not the, you give the fibrin glue, it will immediately adhesive in nature. That is not a way.
there is advantage, but
Of course, of course.
there is advantage and disadvantage of fibrin glue, but it is not the best. There is
তোমাকে সব লেয়ার কাজ করতে হবে, তারপরে ফিব্রিন গ্লু দিতে হবে।
there are many
খালি
studies.
ফিব্রিন গ্লু দিয়ে আটকাই দিবা, এটা হয় না তো।
There are many studies about fibrin glue. So but the result is same, using or not using, but there is disadvantages of fibrin glue as well.
হ্যাঁ, হ্যাঁ, অবশ্যই, অবশ্যই।
But it is not the best. No,
হ্যাঁ, আমি
no.
সেটাই তো বলতেছি।
ফিব্রিন শুধু ফিব্রিন গ্লু তো হইতেই পারে না, এটা হবে কেন? ফিব্রিন ইউজ অফ ফিব্রিন গ্লু শুধু ফিব্রিন কেন হবে?
Clean it. Clean water.
Sir, fascia, fat, mucosa, mucoperichondrium, cartilage, hydroxyapatite, there are different types of grafts and implants. But fibrin glue is additional. এটা কেউ দেয়, কেউ দেয় না। হ্যাঁ।
Let us see if it works with the microscope now.
ওইসব জায়গায় অনেকে unnecessary fibrin glue ইউজ করে। Socio-cultural, social, socio-economic factor is a great factor, sir. আমাদের SGM চৌধুরী স্যার বলতেন, তুমি কাকে সেফট্রিয়াক্সন দিবে আর কাকে জেন্টামাইসিন দিবে বুঝতে হবে। তা আমাদের এখানে 18,000 টাকা একটা বিরাট ফ্যাক্টর। না, যদি এটা না ডাক্তারের মানি থাকতে পারে, রোগীর মানি থাকা লাগবে তো।
না, 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 এখানে মানির ব্যাপার না, এখানে ইথিক্যাল ইউজটা ইম্পর্টেন্ট, সেটা
এবং
চিন্তা করতে হবে।
ইথিক্যাল
মানে
এবং
কি আছে?
আমি কোনো অ্যাডভান্টেজ দিতে পারতেছি
দরকার
কিনা আমাকে
কিনা?
বুঝতে হবে।
পরে আবার স্টার্ট হলো, তোমার প্রশ্ন করবে যে ইউজ ছিল, এটা তুমি ইউজ করো না কেন? তোমার কোনো অ্যানসার নাই।
ফিব্রিন গ্লু না স্যার, স্যার স্যার না এখানে একটা কথা আছে স্যার, ফিব্রিন গ্লু আমাকে এডিশনাল কোনো বেনিফিট দিচ্ছে কিনা সেটা হলো কথা। তাই এখন আমার আউটকামে কোনো বেনিফিট দিচ্ছে না, বাট বেনিফিট দিচ্ছে ওখানে, ইফ আই ডোন্ট ইউজ ফিব্রিন গ্লু আই হ্যাভ টু কিপ দ্য প্যাক ফর অ্যাটলিস্ট 7 days, and if I give the fibrin glue I don't have to give the pack for 7 days. এখানে পেশেন্ট একটা কমফোর্টের ফ্যাক্টর আছে। এখানে যেটা আমি বলি, ফিব্রিন গ্লু কতদিন, ফিব্রিন অ্যাডহেসিভ ইফেক্ট থাকে 7 দিন, আর আমি যদি ওই 7 দিন যদি প্যাক রাখি, এখানে নরমাল আমার টিস্যু ফিব্রিন যেটা আসছে ইট টেকস ওভার দ্য ফাংশন অফ দ্য ফিব্রিন গ্লু, সো দ্য আউটকাম ইজ সেম, বাট advantage is keeping the pack and not keeping the pack. This is the advantage, and disadvantage is, sir আমি বলি স্যার, and disadvantage is the money and technology. So there are advantages and disadvantages. এখন I have to consider patient's factor, surgeon's factor, center factor, and cost effectiveness. So cost effectiveness, কারো কাছে টাকা কোনো ব্যাপার না, আমার নাকের প্যাক দরকার নেই, আপনি আমাকে ফিব্রিন গ্লু দেন, সেটা হলো আলাদা জিনিস। হ্যাঁ, 1.5 লাখ টাকা দিয়ে সার্কামসিশন করতেছি, আমার টাকা কোনো সমস্যা নেই।
Dr. Panja.
Okay,
Okay. We are fighting about the fibrin glue or not fibrin glue.
that's great.
So
Because
now we
no.
are going back to Panja.
Answers are all about.
Okay, Panja, you take the fat.
Now the picture is fine.
Now good, there is a good view.
Now picture is very good.
Okay, thank you.
Okay.
পাঞ্জা এখন ফ্যাট নিয়ে পাঞ্জা করছে।
হ্যাঁ, পাঞ্জা লড়াই হবে আজকে। আচ্ছা, পাঞ্জা, ডক্টর পাঞ্জা।
Yeah, tell me, sir.
You take a fat in single piece or multiple pieces?
Single piece is better.
I usually prefer to break the fat into multiple pieces first,
Okay.
because the reason is that it will depend how much you need, and you will be surprised to see how less we need here. So the entire thing that I want to highlight is that you actually, a little bit of lobule fat is more than enough. Now, the problem that I'm facing here is that I wish I had the right kind of instruments, because see, putting it there, then, a dissector is very important here. I have just stuck the fat on the tip of the scissor. Let's see. So here I wish I had a dissector kind of an instrument that I can, giving me a little difficulty. Or maybe if the sickle would have had a handle, it would have been nice. Let's see. I need a blunt something. Wait. So let's see if I can get this. Okay. So we have put the fat. You can see that the sulcus has been elevated from its bed. Okay, the depression is not there. What you can see is that the thinned out sulcus, but in microscope when we are seeing, it has actually got elevated from its bed. Okay.
Okay.
So now there are two ways. Either you can put some fibrin glue on the suture line.
Yeah.
That helps. Okay, that helps wonderfully actually. Or else we have to try to just put a bite, a suture. Let's see, with the existing instrument we can do it. I'll see if I can put another small bit of fat. Give me a scissor. Okay. Okay. Now, Okay, give me the scissors tip. Or maybe this one, let me see. Here, ideally, you need to have a straight blunt instrument to
Overfed introduction is more benefit than the underfed. বেশি দিলে তো ভালো হয়। Absorption হয়ে যাবে।
why we are, yes, true, it's very true. That is the reason why I'm putting a little bit extra.
Yeah,
Because some amount of overcorrection is always helps, because you know that at some point it's going to get absorbed.
Yeah.
Okay. So now we have adequate correction. So what we'll do, let's see. It's tricky, but if we can do it, because we don't have a fibrin glue, I'll try if we can put a small suture bite. So again, if you have a wide bore laryngoscope, it helps, or sometimes a Wiedemann laryngoscope where there is a space between the blades so that you can manipulate your. Okay, bring out the suture, show me. 50. Now, ideally, if you have to suture, there should be, you need a proper grasping forceps. Okay. So let's see. Rapid or এটা দাও খুলে বাইকে জেলি দেবে ঠিক আছে ঠিক আছে জেলি 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 যেসব জেলি যেসব জেলি
লম্বা হ্যান্ডেল থাকে তো লাইনিং দিলে নিডল আছে
ওকে
পাকা থাকে ওর মধ্যে নিডল দিলে আপনি এখানে থাকলে
मतलब जली चला हुआ है ठीक है ठीक है
Vicryl you are using
lubricate করে না because vicryl is very dry otherwise. Okay. Let's see if it can actually help with this. Slipping, I need to grasp it. Acha, I'll just first introduce it. We are trying with a 5-0 vehicle, but still the needle is bigger in comparison to that area.
ভালো হয়েছে 80
Hmm.
নাই অহেদ 80
There,
80 নিডল ছোট
if it is there, you might get it from plastic surgeons. Because what you need is a small needle.
Dr. Panja,
Yeah,
is there any special needle other than this? Like there is
a special needle, it is not readily available. You know that Lichtenberger's needle is there, that is different. But for this suturing, special needle, you have what we need is a small and with a smaller curvature. Because you see, it's a very limited space there, no?
Yes.
So it is only when you don't have a fibrin glue. If you have a fibrin glue, then you can just put few drops on the margin. That is enough,
Yes.
good enough. But you can see that the elevation of the complete elevation of the sac is there. And
So game is going on between Bangladesh and Pakistan. Cheers for Bangladesh. 64
of
for
course,
one. Okay, Panja. Very nice surgery. Enjoying.
thank you, sir. Thank you. Let's see.
Dr. Panja, hello,
Yes, sir.
a distending type of laryngoscope.
Yes. We need that.
What the distending type of?
That is what we need in this type of surgeries, na? Because as I was stressing in my lecture yesterday also, it's all about your exposure.
Yes.
Hmm. It is also. No. Micro point. This is what? It's a round bodied, na? It's a yes. Always. It's a full. Let's. I hope it works. Yeah. I hope it works.
কাদের ভাই এটা একটু লাইটটা কমায় দেন দিবি না
অল্প দিলেই হবে।
লাইট কমায় দেন
Still it looks big.
নম্বর আছে
It's okay. দাঁড়াও. We have to do it from the other way around. Let us see.
আমরা ওখানে বসে বসে লিখতে করে হবে আমাদের না ভালো হবে
ক্লাব পাইতে পারে। হ্যাঁ, ওখানে সেলাই দিচ্ছে, বিশাল ব্যাপার, এটা কঠিন ব্যাপার রে ভাই। এটা সোজা হাত
Slipping. It is, the forceps is slipping actually. You have something like a crocodile kind of thing. अच्छा, ठीक। काफी बड़ा है ये, मोस्ट आउट। हाँ, इधर लेंथ पे पाओ जावे कि नहीं। ठीक है, let us try. I wish we had a, because fibrin glue would have worked very well here.
Easy to see, but difficult to do.
We don't have a bigger laryngoscope actually.
Yes.
And with a laryngoscope, the advantage is that you have two blades. So you have
Yes.
some area of rotating.
Very difficult job. Oh, acha.
We need us actually, this is the minimum that we got. It is 6.0, but still the needle is a bit bigger. What happens is that the moment it hits the walls of the DL scope, the orientation changes. That's why in VIDA laryngoscope, you have got a space between the two blades where your forceps can manipulate. So you just have to be lucky. I don't know whether eventually it is going to work. The entire length is, yes, one. This is the entire length of width of the vocal cord. Its needle is too big. It won't work. We need an even smaller needle. Is it there? Do you have 80 something? 80? Because the length of the needle is more than the width of the vocal cord. So you need very fine, very small aperture ones. Something that you use for microvascular surgery, those type of forceps. Because it's nothing, only that we are not getting the space to maneuver. That is the only problem.
Sorry, Panja. Actually, I talked to the glue people. Now he says it takes time. So
Okay.
sorry, sorry for inconvenience.
Anyways, we'll take one last try if we can get a 80. Just one bite would do for us.
Dear audience, side by side, we have a session now. Our respected teacher, Professor Ramlingam, he will deliver a lecture on thyroplasty type 1, 2, 3, and 4. Thyroplasty type 1 to type 4. I request Professor Munzurul Alam, Professor Nurul Fattar Rumi, and Professor Alamgir Chaudhuri to come over the dais and chair the session.
এটা তো খোঁজ নিয়ে নিচ্ছি আমরা ফোন নাম্বার
বহুত বড় রে।
I request Professor Ramlingam sir to come over the dais and deliver his lecture.
এই জোর ভাই
জল পাবে জল hello yeah I think no I'm checking out welcome to the thyroplasty session. Thyroplasty type 1, type 2, type 3, 4 will be delivered by Brigadier Ramaningam. So welcome everybody to concentrate to this presentation. Brigadier Ramalingam, please. Thank you. Can we have the can we have this particular thing on screen? IT. Thank you. IT. Screen.
At the outset, I must say that I'm really grateful to Professor Kamrul Hasan Tarafdar and his team for inviting me to this auspicious fifth Laryngology and Voice Association of Bangladesh. Really, I'm honored, and it's my privilege that I'm with you. Yesterday, we operated 2 cases. The second case was really difficult, and somehow I could do some justice. Hopefully, the patient will recover that laryngotracheal resection and anastomosis, because the cricket cartilage also was involved. I had to do a cricotracheothyropexy. If you read about it, you'll find that the trachea has been sutured to cricoid cartilage as well as thyroid cartilage. So that becomes cricotracheothyropexy. Right now, I'm going for laryngeal framework surgery. May I start, Chairperson, sir? Mr. Chairperson? Or you want to say something? Should I start?
Yes. Yes,
Okay.
please start.
So laryngeal framework surgery, or this is the hospital where I'm working. It is VL Kapoor Memorial Hospital. Actually, 10 years back, I left army. I took voluntary retirement as Brigadier General, and then after 30 years of service, then I joined this corporate hospital, and since last 10 years, I'm with them. This is my team. You all know Dr. Anisur because she had come to Bangladesh also. So she is my teammate for Delhi Voice Clinic. So laryngeal framework surgery or phonosurgery or thyroplasty, I'll go about it side by side. Thyroplasty is actually the word coined by Professor Ishiki. Unfortunately, we lost him this year, about 3 months back. And he is regarded as father of phonosurgery. Laryngeal framework surgery is a European association. They have coined this term, encompassing a lot of other surgeries also inside. And phonosurgery, any surgery to improve the voice. Maybe even if you remove a vocal cord polyp or nodule or a cyst, that will be also regarded as phonosurgery. So I pay our deepest homage to Professor Ishiki for who has revolutionized this concept of phonosurgery. How many of you know that Professor Ishiki was actually a plastic surgeon? He was never an otolaryngologist. And believe me, none of the ENT guys developed laryngology except other people. Like starting from Klein Sasser to everybody, Chevalier Jackson, all are non-ENT surgeons. They developed. But we people, we didn't do much to improve the laryngology. Now, the younger generation, probably they will do more, better and better. Now, we'll just go for thyroplasty basics. So, this is thyroplasty. Basically, I'm talking on any work on the thyroid cartilage. This is the midline. This is the light is gone. Hello? Is gone? Hello. Yeah. So I told you the midline we draw from thyroid notch, V of thyroid notch to lower border, and we make a rectangular window at the level of vocal fold parallel to the lower border, like what I did yesterday, and you carve out. Now the measurements. Vertical measurements are taken from this place. Okay. That is by green arrow, and you have to find out the midpoint from upper border to lower border, which is by blue line. The midpoint is designated by red arrow, which will show the level of vocal fold. Here is the place where antecommissure is attached. So we, as I told you, we have to make a rectangular window at the level of on the affected side of ala, parallel to the lower border of thyroid cartilage. And usually we put about 4 to 5 millimeters away. 4 to 5 millimeters away in case of the female, and 5 to 6 millimeter away in case of male. And the height and all I'll tell you later. So window measurements. See, remember, male larynx is bigger than female larynx. So male larynx, the height of the window is a little bigger, 5 to 6 millimeter and 12 to 4 to 15 millimeter. Yesterday we did 5 to 12 millimeter. And the female, in case of female, the height of the window is 4 to 5 millimeter. Why this 4 to 5, 5 to 6? Because inferiorly you should leave at least 3 mm strut, so that it doesn't fracture when you are putting the implant. And width 10 to 12 millimeter in case of female. And the important portion in this thing is this particular posterior-inferior quadrant, the angle, it should not violate the oblique line where the strap muscles are attached. This is the oblique line. Why? If it goes, what happens? It will push the arytenoid cartilage. So we don't want that. Now, this is something I wanted to show you. This is the injection laryngoplasty, where the paraglottic space is filled with filler, like maybe hyaluronic acid or hydroxyapatite or fat for medialation. And this is the thyroplasty. And this is arytenoid rotation. Why and how, I'll tell you later. Now, lot of silicone implants shape has been changed. This is originally type A is originally devised by Professor Ishiki, then became type B, and James Kaufman, he made it into a boat shape, which I used yesterday. I prefer this boat shape because this portion, it medializes the mid portion of the cord so well that the voice quality improves. Now the changes of implant, this is typical thyroplasty type 1 silicone block. Montgomery implant is available in India, but is very costly. That's why I've never used, because the set is itself is 75,000 to 80,000. Netravelle, I didn't purchase the thyroplasty set, but I have used the implant, 3 implants I used. One after 10 years it extruded. Viocom, it has not come to India. It's just for academic interest. I am showing you because it has got a self-locking system. There is a locking mechanism to prevent extrusion. Gore-Tex, I'll be showing you a Gore-Tex video. Gore-Tex is available in CTVS theater. You can ask your CTVS colleagues to give you Gore-Tex. It is very nice. You can put it just like as you pack the nose with ribbon gauze, in the similar manner, you have to keep on packing till you get satisfactory result. TBFMI, it has been devised by Professor Gerald Frederick of Austria, and we have used about 36 cases. And the advantage is very quick and very nice, secure, no extrusion. But the only disadvantage is the cost factor. It is about 17 to it is about 20,000 in Indian rupees. I will be also showing you a video how TBFMI is inserted.
There is some new development which we have done. Dr. Ashok Purohit of Sangli in Maharashtra, he's a good friend of mine. He used this titanium mini screw to medialize the cords. And in this case, one of your colleague, I'll be showing his video. He came from Bangladesh, and after doing the type 1 thyroplasty, we found that his voice is still lacking. You require one more, you require arytenoid reduction. So instead of doing arytenoid reduction, I used 12 millimeter of this titanium screw, and I medialized the arytenoid. Now, what are the advantages? Operation is restricted to external laryngeal cartilages. You are not touching the vocal cords at all, so there is no scarring on the vocal cords. And it is a reversible procedure, safe procedure. Quality of voice production is far, far better than injection laryngoplasty. Now, arytenoid reduction, why? Larynx consists of two biomechanical subunits. One is membranous part, which is anterior, and posteriorly is the cartilaginous part, consisting of arytenoid cartilage and cricoid cartilage. So, if there is a posterior glottic gap here, then comes the problem, because you can only medialize the anterior portion, this portion. Okay. Whereas this portion, it is very difficult to medialize with only silicon block or thyroplasty. So, what Ishiki again in 78, he found out something called arytenoid reduction procedure. What he used to do is, he used to dislocate the cricothyroid joint and then go in and take a suture through the muscular process of arytenoid and bring it out anteriorly so that the arytenoid rotates on its axis. This will mimic the lateral cricoarytenoid muscle. So this is the vector and it rotates. Once it rotates, the vocal cord comes to midline. You take figure 8 suture. Then Maragas, he created a C-shaped window posteriorly on the ala, and this I do very regularly. I'll be showing in my video also. You take a bite, figure 8 bite, and bring it out anteriorly and tie it. By this, you achieve your arytenoid reduction, and the voice immediately it improves. Now, this is type 1 thyroplasty. I have borrowed this video from my colleague. Now, I have done the shooting and everything, editing. So, she performed the surgery. This is to show hyoid bone, thyroid cartilage, cricoid cartilage, and we give local infiltration.
Give me the straight.
And because we are elevating the strap muscles. Once the strap muscles are elevated, the strap muscles are separated in the midline, and we elevate on the affected side. This is on the right side. Now the measurements are taken, like I explained to you. This is from midline out. You take a little laterally, about 5 millimeter. And instead of using the marking pen, I use cautery to infiltrate, to make the marking. And this is, as I told you yesterday, the lower border, I devised this one. I put the scale because there is a thyroid tubercle which protrudes downwards. So if you follow the thyroid tubercle, your window becomes oblique. I don't want that. So once you have done it, you measure meticulously and decide the window width and height. So now the window is being created. We are outlining with the help of cutting cautery. Once you have done that, I am elevating the thyroid cartilage, the at the window, and we are trying to cut it. Now the window is made, and the finer touches are done, and the inner pericardium is elevated all around, so that the medialation can you see the medialation can take place. Very nice it is. After that, we again measure the windows to show that it is proper. Now comes the carving of the silicon block. Like as I told you yesterday, how to do the carving. Here meticulously we do a boat-shaped carving, like I showed you earlier. Take one.
Straight scissor.
Once that is done, so this is the boat-shaped silicon block. Now I score this because once you score, you can bend the implant like this. Why you want to do this? Because while inserting, first you have to insert the posterior one where the depth is more, and then gradually you put it inside the front portion. Sorry. So here we are putting, and the anterior portion is actually 2 mm because we don't want to medialize the anterior commissural area too much. It will create strain in the voice. So it's being inserted, and first posterior and then anterior, then you push the entire mid one. Once this is done, we check the vocal cord position using this is now in position. We use the fiber optic laryngoscope to visualize the cord position. And once we are satisfied, we take the implant, we secure the implant with 3-O-Prolene so that it doesn't extrude. After that, the wound is closed in layers after placing a mini-vac drain. Okay?
Hello. My name is.
No, I'll show you. This is arytenoid dilation using TBFMI. Again, surface marking. And we have, when we are planning for arytenoid dilation, we cut the strap muscles. Otherwise, you cannot visualize the posterior portion of the thyroid ala. So we have done, now we take the measurements. Here, that is the window. Yeah, there are too many videos, so that is why I'm just doing a little bit fast forwarding. This is the inner pericardium. Once that is done, this is the TVFMI. I have inserted and I was seeing that how much it is. Now I am doing the Maragos window for arytenoid adduction, because when we put the TVFMI, we examined, we found that there was a posterior glottic gap. And posteriorly, this patient had a lot of calcification, so we had to use a drill. Now here I'm making a tunnel medial to the thyroid ala, so that from there we'll take a bite. Now, this is the lateral wall of piriform fossa, that C-shaped cartilage which we removed. So you have to be very careful. Now we have taken this suture. This is thyroprolin suture through the muscular process of arytenoid, and we are bringing out anteriorly. Once you do, you have achieved your goal. This is the TVFMI. The special plier comes for bending, because you have to be very careful. If you bend once, you cannot redo again, because if you redo, it will break. And these two holes are meant for securing it. Like I'm taking thyroprolin here and pushing it inside. Pushing it inside and placing it and securing it very nicely so that it doesn't extrude. Once that is done, we again see the vocal cord position. And now the strap muscles which have been cut, they are sutured back and wound is closed in layers. Can I have the sound? Excuse me? This is after thyroid surgery. The patient had unilateral vocal cord palsy, and we did type 1 thyroplasty.
हाँ जी, मेरा नाम जसबीर कौर है। मेरा कल ऑपरेशन हुआ, उसके साथ मेरी बहुत ही सुंदर आवाज आ चुकी है, तो मैं बहुत ही
Okay. Now, this gentleman I was telling you where I use the titanium screw, he is a physician from Bangladesh. Some of you might be knowing.
Dr. I'm from Bangladesh. I developed left-sided vocal, left-sided.
He had a thymic surgery, following which he had cord palsy.
That was done on December 2040.
And this is his post-operative voice.
My name is Dr. Anisur. I am from Bangladesh. I developed first sense of voice following thymectomy operation. It was done in 2014. Yesterday, my thymectomy, thyroplasty type 1 operation was done, and I am okay.
Now, this gentleman, again, I gave a live surgery demonstration in Pune. There, if you see, there is a huge posterior glottic gap, and his voice is like this. This is following a surgery on esophagus. Now, this is post thyroplasty with arytenoid adduction, and this is his voice.
मेरा नाम नरेश शाह है। 1 साल पहले मेरा ऑपरेशन हुआ था, उसके बाद मेरे आवाज में बहुत फर्क आ गया।
Now, as I told you, Gore-Tex, this is a very simple procedure. We are just showing you how Gore-Tex is inserted. Now, why we did in this case, this patient had type 5 cordectomy for CL larynx. We waited for 2 years when he was symptom-free, disease-free. We wanted to do a thyroplasty, and thyroplasty for restoration of voice. You can see hardly any voice. Now there is no vocal cord. You see the stroboscopy. See, there is absence of vocal cord mass. So if I put a silicon block, it will extrude. This is the NBI, and again surface marking. Here we actually create a very small we use a very small window because you don't require a big window. So The window measurements are done and we made 5 mm by, I think 6 mm. Very small window, you can see. It was calcified. And we elevated all around. We are taking a thyroprolene suture through and through because we want to tie it later. This is the Gore-Tex 4 mm strip. We are using 4 mm strip. Is a long strip. So you keep on stuffing in the pocket what you have made. Here only anteriorly and little bit superiorly and little bit inferiorly you require to, and of course posteriorly. So once you've done, your angulation is towards posteriorly. So once you have achieved desired voice, then we check with fibroscope whether it is proper, and then we secure it with thyroprolene to prevent extrusion. And then of course you close the window in layers. Now this is one lady.
मेरा नाम कमला है। मैं यूएसए में मेरा थायराइड का ऑपरेशन हुआ था।
She had
उससे
surgery in
आवाज
US.
बैठ गई है। अब मैं इलाज कराने हॉस्पिटल में आई हूँ।
Now this is her voice.
मेरा नाम कमला है। अभी सर्जरी हुआ 2 घंटे पहले। अब मेरा आराम है।
Just 2 hours
आवाज
before the
अच्छी
surgery
है।
was done. Now we come to type 2 thyroplasty. Forget about 1, now come to 2. Indication, adductor spasmodic dysphonia. We have done about 15 cases only, not many, because our gold standard is first give injection Botox and then you do the type 2 thyroplasty if patient is still insisting. Now, what we do, I'll tell you. First, you keep on listening.
This is the preoperative voice of ex-Havildar Pandhari.
This is typical of spasmodic dysphonia.
This is the post-operative voice of ex-Havildar Pandhari, who underwent type 2 thyroplasty.
मेरा नाम एक हवलदार पंडरी है।
So this spasm
मेरे
is
गले का
gone.
तकलीफ की वजह से बोलना मुश्किल था, इसलिए मैंने कमांड।
So what we do in the midline, we give an incision and separate the thyroid ala, and we try to separate to desired length, maybe 4 mm, maybe 5 mm, like that, and we say keep the thyroid ala separately by putting silastic block so that the vocal cord assumes this position, means relaxed, so there is no spasm. However, I'll just show you brief video and how we do it.
The midline.
This is one of my very old video. After that, I stopped doing. Recently, I modified the video. I mean, the technique. I'll show you that in more detail. Here in the midline, we are separating. This patient has
Structures should be protected using spheres.
You must not injure the inner pericardium, remember.
Are attractive naturally.
And these are the silastic small blocks.
Elastic block is
We
used to
make
measure
3 mm,
amount
4
of
mm, 5
distraction
mm
with
and try to put it and see
usually 3 to 4
when
minutes.
these spasms disappear.
The voice is tested intraoperatively.
Now, once we have done,
Additional
we have
elevation
decided the weight. In this case, we have done 5 mm.
which have been
So
sterilized.
we are making this T-shaped.
The implant is now placed in the gap created by the split cartilage. This achieves lateralization of the thyroid areas and indirectly the vocal folds.
So once we do, you have to secure it. We secure, the securing is a very
patient's
difficult
voice
job.
is now tested. For the implant is grippers, which are used.
So once, now this is the old method.
Tightly
Now let's
secured
go for
to the cartilage
new way,
to
how you
prevent any
should do it.
chances.
This is what
ये मेरी वॉइस लगभग 2 साल है
this young
खराब हो
man
चुकी
had
है
4 or 5 times Botox
और
injection.
इसके लिए मैंने बोटॉक्स इंजेक्शन भी लगवाए हैं 3-4 उससे वॉइस मेरी क्लियर भी हो जाती थी 2-3 महीने के लिए और फिर आई ईट एप्पल्स एंड ऑल ईयर.
So again, surface marking, and we are separating the thyroid lamina in the midline. And these are the mini plates. We are using thyroid, the titanium mini plates, like Japanese people, Ichiro Tataya, if you have heard him, he uses titanium bridge. Now, since they are not marketing, we thought we'll use this titanium mini plates to mimic the kind of bridge. So I did this after a lot of thought, because this gentleman was very keen. He was supposed to get married. He wanted his voice to be better. Otherwise, his wife would have divorced him. So that's what, or she would not have married. So I'm bending it. We found out that he requires only 3 mm separation. When we did 4 mm, he was having breathy voice. He didn't want it. So you may be, I hope you are able to see that I'm bending it very nicely and making it a shape. This is the shape, final shape, so that it goes in between the ala of both sides. Now we assess his voice. Once his voice is assessed, this is now secured with the help of thyroprolin, and also we put titanium screws. So once we have confirmed our findings, there is no spasm. Now we are using 4 mm screws also, apart from thyroprolin. This way we secure the titanium plate, and titanium plate will not extrude or get displaced. Then we close the thing in layers.
अप्रोक्स 1.5-2 साल
This
हो
is
गए
the
थे
post
और
of voice.
वॉइस मेरी बहुत खराब थी और अब मैंने डॉक्टर रामलिंगम सर के जरिए थायरोप्लास्टी टाइप 2 करवाई है और अब मेरी वॉइस काफी क्लियर.
Result straight away on the table. So now let's come to type 3 thyroplasty. I think Dr. Babar has done lot many. Yesterday he showed. This is shortening of vocal cords. In case of pitch lowering, usually done in puberphonia. What I am doing actually, we are using mini plates while taking the sutures so that it doesn't cut through. I'll just show you. I have to forward this. So on both sides, about 3 mm away, we have given cuts so that this anterior commissural retrusal occurs. You elevate the inner perichondrium on both sides. We have nicely elevated. Now we are testing by pushing the anterior commissural area. I am using these mini plates. Why I am using the mini plates for tightening? Because it doesn't cut through. Usually, otherwise, the patient is swallowing 6 to 7 times a minute, and usually it cuts through. So we have taken to keep the position, keep the retruded portion of the thyroid cartilage in position. We are keeping there, and now we are tightening with the help of on the top of mini plate. So once we are satisfied, we are closing it there. Now we are approximating the strap muscles and closing. This is the voice. He came from Afghanistan with this kind of voice, 42 years old man. Now listen to his post-operative voice. You know, when he rang up his wife refused to talk to him, telling that you are imposter. Then he had to tell somebody else that please tell her that. And he came to me with annoyed that, look, my voice has become different. My wife is not recognizing me. I said, don't worry. Now, this is another very interesting story. This is about 19 years old boy. He was after to go to college because of his voice. Even girls used to tease him. And he was very shy of going to participate in debates and all that. So we did type 3 thyroplasty.
It's not the way it should be. I am Binay, student of Delhi University, studying BCom past.
Now this is his voice.
My name is Binay Preet.
You know, he's tall, handsome, 6'2" inches, very handsome guy. But with the kind of voice he had, now he came back after 2 months. He said, sir, I'm so happy that I am able to participate in debates and I have lots of girlfriends. I said, very good. So now we are coming to type 4 thyroplasty or anteroposterior elongation by cricothyroid approximation. Where it is done, usually in gender reassignment or cricothyroid muscle paralysis. This is one case where patient had androphonia. We did a lady had androphonia. So we did type 4 thyroplasty. And this is one I'm showing you. This patient had bilateral SLN palsy due to head injury, rotor accident. Very unusual. But we diagnosed and we did the cricothyroid approximation. This young girl, again, we used titanium mini plates to tie over because it will not cut through. Otherwise, you are taking through cricut cartilage and thyroid cartilage. Usually, it cuts through thyroid cartilage. So you put the titanium mini plates like this. We have put, and we are taking suture through that. And we close with a drain in situ. This is my website. And before I close, I always try. This gentleman, we did additional direction with thyroplasty. And who said they can't sing? They can sing much better. It's a prayer to God in Telugu language. Thank you very much for your patience.
Thank you. Thank you, Doctor. Any question you can?
Yes, sir.
You can ask any question if you have. Hi, Dr. Ramalingam sir, I'm Dr.
Yes.
Babur.
Hello.
Yeah. Okay. Thank you very much, Dr. Ramalingam. You are a voice magician, I can say.
No. He's my.
Thank you very much indeed for your nice demonstration. Yesterday, you had a live demonstration. Today is a video presentation. Everything is fantastic, excellent. I am Professor Martin, working as the head of the department, Sohit Medical College. Is one of the tertiary level hospital here in
Okay.
Dhaka.
Thank
It's
you.
about 1800 bedded teaching hospital. Now, actually, my question is regarding the type 1, thyroplasty. We are using Gore-Tex ribbon gauze, like,
Yeah.
rather than silicone. So the way you are, putting this one for the newcomer, for the beginner, those who want to do the surgery, I think rather than measuring the, millimeter by millimeter silicone, all this implant, cutting this one, lots of difficulties, rather than make a window and put these cartons, very easily. My question is, how long it stay actually? Is it permanent, the Gore-Tex, or is it can?
No, it is permanent. No, I'll answer your question. I was very reluctant to do this surgery.
Yes.
Honestly, because I had taken out one due to migration. We are putting everything like ribbon gauze in ribbon gauze,
Yes,
in
yes.
layers.
Yeah,
Now we are swallowing at least 5 to 6 times a minute.
right,
So there is a chance that it will migrate
right.
upwards or downwards.
Yes.
When the voice goes bad, now you have to reoperate. You have to take out. Taking out is the most difficult portion.
Oh, I see.
So I have just done about 3 cases.
Right.
Not more than out of 350 thyroplasties so far.
Yes.
I have done only 3 cases. And those 3 cases were difficult ones. That's why I had done, because the lady had radiotherapy and all that. So I didn't want to create a big window. Then another patient, he had a very short neck. So we decided we'll make a small window and put it.
Yes.
So like that, there are very specific indications.
Right.
Otherwise, it's very easy. But where do you get it? A common man will not get this Gore-Tex.
Yes.
You have to have a teaching institute where CTVS center
Right,
is there.
right.
There only you can get Gore-Tex.
Okay.
So for experience sake, we have done about 3 cases.
Right.
That's I'm sharing. But otherwise, if you ask me today, which is the best in the material, it is silicone implant.
Silicone.
Very cheap. Only 1,000 rupees per person is the cost of
Oh.
this thing.
Thank you very much. Now, regarding the type 3 thyroplasty, pure phone patients, usually lots of patients we have, dealing every day. So when the patient come to us, they like that. Like that, right?
Yeah.
So I just demonstrate the patient like, look, you are talking like that. If you talk like that, you'll not get any girl to marry. I'm sure I'm giving the, that ultimately with the speech therapy, drastically improved, rather than so. Definitely there is a thyroplasty is an option, but before that, actually, your message to the audience.
I agree.
Yeah,
See,
thank you.
first and foremost, remember the gold standard of any puberphonia is send him for speech therapy for 3 months. After 3 months, if it does not improve, then only put your knife. Don't
Yes.
be a knife hungry and go straight away for
Exactly,
surgery.
exactly.
All my patients, they have undergone speech therapy number of times, and then only when they come, I operate.
Yes.
Please don't be knife hungry
Yes.
when you are treating a patient.
Yes.
Sir, Ramalingam
Thank you.
sir.
Yes.
Yesterday I have shown one patient. Just he came with puerphonia for last 3 years. From starting of puberty, puerphonia starts. So patient came to me, and in the chamber, I have done the Goodsman test, and in the chamber, his voice was corrected. And this is not very common, but the most common thing is the patient gets more than 95. I think more than that, the patient gets better or improves totally by speech therapy. Only in a few cases, thyroplasty may be needed.
Yeah, absolutely, absolutely. Like one medical student came to me,
Thanks,
and
Babur.
I found out puberphonia.
Babur, instant surgeon.
I sent
Instant
him,
result. Yes, please.
yeah, I just sent him to a speech therapist. 1 hour session, he comes back speaking normally. I said, now you are happy? He said, yes, sir, I'm very happy. So like that also can happen.
Thanks, Brigadier Ramalingam, for your excellent delivery and excellent
Yeah,
video. My question is, in case of rhinoplasty, it is said that if after 5 years, his or her shape of the nose is all right, then it is told that the operation is successful. Now, my question is, after thyroplasty type 1, 2, 3, 4, for how many days the patient should be followed up? And after how many days you can tell, okay, you are perfectly all right? Is there any parameter? Is there any parameter for follow-up? For how many
I'll
days
tell
to
you,
be
I'll
followed?
tell you. First 24 hours, we say that go slow, don't speak. For 1 week, the patient will have slight brassy voice. Why? Because of edema of the vocal cord. It takes 1 week to subside. After that, you can do normal. So we usually after 1 week I see, and then after another 2 weeks I see. When I find that there is no edema and anything, I say you go. You are absolutely fine. There's no need. And usually within 2 to 3 weeks, the mucosal wave pattern comes up in stroboscopy. At the time you say that you are absolutely fine.
In case of bilateral or vocal cord palsy following thyroid surgery, what you do?
No, then it is Kashima surgery.
That's Kashima,
Then
bilateral for Kashima. Now I have one question. I have one question.
Yes, sir.
With Professor Babur, he told that speech therapy is first.
Yes.
Do you do every patient thyroplasty?
Yes.
Or first
No,
speech therapy?
No. Type 1 thyroplasty for unilateral vocal cord palsy, I do not touch before 6 months.
Right.
Because in 6 months' time, he has to undergo speech therapy.
Right.
I only do not thyroplasty if the patient is a professional voice user, like a teacher,
Right.
like a person who has to speak on phone. In such cases, I tell them you do speech therapy. At the same time, we do injection laryngoplasty, which is done in OPD.
Right.
We inject the filler. I had a video. I
Yes.
didn't want to show because I thought I'll be exceeding Dr. Professor.
Then
Kapur
what
told
about
us
the
to say.
singer? What about the singer?
Singer also, we give them speech therapy and we try to inject because the filler, they last only 3-4 months. It can disappear. So we first give injection laryngoplasty. I've got an excellent collection. We have done more than 30 cases so far. So results are excellent. That is first. And 6 months, don't do thyroplasty
Exactly.
because it is not correct.
Exactly.
It is not
6
correct.
months or more. Maybe 1 year. You can take
Earlier
that.
people used to say 1 year, but we over the years we have found out, and there are so many literatures also. 6 months is good enough. If anything has to recover, it will recover. But when you are doing a stroboscopy, you find that there's little bit of movement, then don't do thyroplasty.
Of course. Right.
Actually,
And another, I have another question. Do you have any experience of revision surgery?
Sorry, revision surgery.
Yes.
I had done one where one of my junior, he did a thyroplasty, where the implant size was small. So he put another small sheet to make it more medial. And that patient came within 6 months, he came to me. So I had to remove that and I had to put another proper one.
Yes, but is smaller is problem, bigger is also problem.
Bigger, yes,
Yeah.
it will
So
have a
what-
strained voice.
What are the disadvantages to insert the,
Sorry?
what are the disadvantages, difficulties to insert the?
See, in silicon block, taking out is very simple. Like yesterday also, I showed just pull out.
You do it quickly, but you are an
Quickly.
expert.
Where
For
you
the
are
beginner, what are the difficulties to insert the?
Sir, I'll be honest with you. When I started my thyroplasty, I did by reading Ishiki's article 15 times. Then it sunk into me that I have to take the measurement from V of thyroid notch to lower border. Otherwise, I was taking from upper border of ala to lower border. So
How
I
you
realized after reading 15 times.
Yes.
Then I did my surgery. I did 5 cases and presented in Pune UI conference. And people in Pune, nobody had done that time. In the armed forces, nobody had done that time.
Another thing wants to know for junior hours, beginners. I don't do thyroplasty, but we have to know about the thing.
So,
If you accidentally injure the mucosa,
We'll close it here.
how you?
inner mucosa?
Yes.
Inner mucosa, we deliberately we cut now.
Accidentally.
No. We
Or
deliberately-
anyway.
Sir, we deliberately cut now.
Yeah.
The old Ishiki teaching was if inner pericardium is breached, abandon the surgery, go back again.
Right.
But now that is out. We
Right.
cut. And
Right.
that is how the
So,
implant
yes.
can go very easily.
Yes,
For
you're
5
right.
years, I was doing without cutting. After that, no. It is almost from 98 onwards, almost 24 years I have been doing. And this is my experience in last 20 years. I have never spared the inner pericardium. I used to
Sir,
cut superiorly, posteriorly and inferiorly so that implant will go very easily.
Yes.
And nothing happened.
Thank you. Thank you very much. Thank you very much. Nice.
Our any question?
Thank you, sir. Thank you. Thank you.
No question.
Thank you. No,
So
time
thank
is
you,
time
thank
is
you.
short.
There is so
thank
many
you, everybody.
thyroplasty.
Big
But-
applause for.
Before that, there are so many Ramalingon in India, but he is a voice Ramalingon, Ravi Ramalingon, KK Ramalingon, but he is famous for voice Ramalingon. We are very much excited. His presentation is very excellent. We enjoyed your presentation. Thank you. Welcome again and again to
Live surgery
Bangladesh.
also.
Thank you, my
Live surgery
chairperson,
also.
sir. You are very gracious. Thank you.
ঠিক আছে, শেষ করে দাও। Next session. Thank you.
Okay, I think we'll finish now.
Sir Kamru.
Thank you, really. Fantastic.
Somehow, hello.
Hello.
Yeah, we have been able to put the fat and somehow put the suture.
Oh, hello. Operation theater.
Yes.
Can you hear us?
So, yeah, this surgery is over.
Can you
We
keep
have
on the
put a 8-0 suture, very fine,
Yes.
almost imperceptible.
Yes, yes.
And we have closed it, put the fat graft on either side. And I think with this, we will finish the surgery. It was
Okay.
really tricky, very difficult, but with the limited instrumentation, this is the
Yes.
best we could do.
But you did a
Uh,
great job anyway.
Thank you. Thank you so much.
Thank you very much.
No, Dr. Anisur. Over. Chalo. Both the needles are out. That is most important, no? Fine. Okay.
Cowdery. Thank you.
Quick, hey, hang on. Hey, Joy bhai, come here. Come right to me. Yes. এত বড় একটা ফ্যাকাল্টি, হিউজ ফ্যাকাল্টি। থ্যাংক ইউ, থ্যাংক ইউ, থ্যাংক ইউ, থ্যাংক ইউ। আমি আর নিজে না আরে দিয়ে দেয় লিডারের সঙ্গে আমরা শুনছি মাস্টার খারাপ জায়গা সবই তো সবই তো Hey, Kamal sir, Kamal, Kamal sir, oh,